There was a recent study that came out, and essentially it was looking at California. Since the pandemic, longevity is not increasing. It's stagnant to decreasing. That's a serious concern. I mean, this is now over 5 years since the beginning of the pandemic.
This podcast is all about living as long as we can without succumbing to chronic diseases like diabetes, dementia, cancer, heart disease. And there is much we can do with lifestyle interventions, diet, exercise, sleep, stress reduction, social connections, all play a role in keeping us as healthy as possible. But then, as we are all acutely aware following the pandemic, we are not fully in control of our own health destiny. There are bigger forces at play, factors beyond our personal control that can suddenly change the course of history and our lives. But is that entirely correct? Could we as individuals do more to prevent infectious diseases taking hold across populations, especially in the poorest communities? Hello again, welcome to the Live Long podcast. I'm Peter Bowes. This is where we explore the science and stories behind human longevity. Dr. Tyler Evans is the author of Pandemics, Poverty and Politics, Decoding the Social and Political Drivers of Pandemics from Plague to COVID-19. Dr. Evans, it's good to talk to you.
Great to be here, Peter.
Is that a fair assessment that there is perhaps more than we realise we can do to have some control over these infectious diseases? And of course, we're very familiar with COVID, and especially as it applies to those poorer communities around the world?
It's a great question. I do think that we have a reasonable amount of control or agency, but there's a lot that we do not have control over, and that is really where public health comes into play. You know, public health as a sort of common good is there to sort of provide the sort of the population prevention sort of parameters or barriers or boundaries, almost your sort of your wiring around the lands in which we sort of live. Again, to kind of just for us to sort of live in this sort of free terrain and for us to make sort of individual choices and whatnot. But we have to have some sort of wiring around us to ensure that we're able to kind of make those sort of individual sort of choices.
And I asked that question in part because in your book you say you wrote the book because you want to try to increase personal awareness of where we all stand and our position in the world, especially as it applies to these matters.
Yeah, I mean the goal really of the book is to depoliticize public health as much as possible. Although the current sort of space we're in, we're not moving in that direction, unfortunately. But I'm still optimistic or confident that we will. And number two is to try to promote as much agency as possible for folks to really understand the importance of building that infrastructure so that we can kind of focus on the social and political drivers of individual health outcomes as well as sort of, the sort of common or population or public health sort of outcomes. That awareness is very, very important. And this book is not intended for healthcare professionals. This book is really intended for, sort of lay communities that just want to understand more about why do we continue to have these epidemics or pandemics and how much of it is driven by components that are socially and politically driven.
And that is exactly what drew me to the subject and the book, because hopefully this podcast has the same philosophy. It's aimed at a lay community in terms of our everyday health. Just before we dive into it a little bit more in detail, just tell me a little bit about yourself and your work to date and your experience that's certainly piqued your interest in this area.
Sure, happy to. So I am, I guess on its surface, I am a physician trained in adult infectious diseases as well as addiction medicine. I've worked in a number of different spaces throughout the U.S. and abroad. Most of my career has been focused on HIV and sort of synergistic infectious diseases. We define them as syndemics. So syndemics are essentially coexisting epidemics. They don't always have to be infectious disease that sort of come together and sort of work together in a multiplicative or amplified sort of fashion so that the outcome, again, is amplified. that could, often be behavioral health, including, addiction, as well as mental health crisis. Right now, we're working on a program in New Mexico where I often sort of describe a convergence of sort of three epidemics, which is because we're working in the jails. So one is the epidemic of mental health, two, the epidemic of addiction, and third, the epidemic of mass incarceration. So we're trying to kind of break that cycle of that sort of convergence, and we often see that. So that's sort of a concrete example of those syndemics. But I've worked in community health settings or public health settings in the States. Like I said, a lot of it's been focused on HIV, but you can't, when you're in the exam room or where you're working on the system level, you can't just focus on HIV again. And you really have to think about all the intersecting elements that sort of exist there. And then I've worked in a number of leadership positions throughout the states. I was the chief medical officer for New York City, overseeing COVID operations in 2020. That's really sort of in the beginning until the city was able to kind of stand up their own sort of operations. And I previously had this very useless skill set of understanding the sort of difference between isolation and quarantine, and how to stand up mass immunizations. In a country like the United States, we really didn't have much of a need for that prior to the pandemic, but turned out to be pretty useful there. And then went on to be the incident commander for the Bay Area in California on mass immunizations, and then ended up jumping into to run my own company where we administered over 2 million COVID vaccines in 10 states. We did over 1 million in California. What I was really proud of was the ability to scale and work with government systems to sort of, build capacity in a very sort of, quick sort of surge capacity way, but also really focus on the most historically marginalized communities, because those were the folks, that we as the founders of the company who had been as docs, providers, nurses, working in those spaces, working in the foxholes of health inequities, both in the U.S. and abroad. And we really saw those amplified during infectious disease outbreaks, and that's really what the book is all about. So I spent many years working in the global south, low and middle income countries, working with organizations like MSF, Médecins Sans Frontières, our Doctors Without Borders, other organizations like Partners in Health, worked in the Ebola response twice, worked in war zones, complex humanitarian emergencies. And what I found was really that the feeders into those outcomes in those countries like South Sudan, Central African Republic, Democratic Republic of Congo are not that dissimilar from the United States. The magnitudes of the burden of disease are considerably different, but the feeders, the drivers, the determinants are very much the same.
You've also worked in the city of Los Angeles, where I'm based, in Skid Row, a huge, vast homeless encampment in downtown Los Angeles. I'm just curious, as a reporter, it's something that I've covered for the past 20, 30 years, and depressingly watched very little progress. What did you learn during that time? Learn not only about the cross-section of disease and mental health, but learn about people and the people that you're working with.
Yeah, well, it's still very much in operation. I was just there last week, so we still have operations down in Southern California. So it's called Street Medicines, providing direct clinical services to the unsheltered, unhoused. So that's different from the sheltered, right? So very, very different. The shelter capacity in really most cities in the United States, certainly in Los Angeles, are completely saturated. So there is just not enough capacity for these folks to be sheltered in any realm of possibility. There are some hotel or motel programs that sort of emerged as a result of the pandemic. It's called Project Home Key in the beginning, and then it was Room Key. And that's, again, provided some capacity. But a lot of these folks don't actually want to be sheltered as well. So anyhow, what we're talking about is the unsheltered, and that makes it a little bit more complicated, right? For years, decades, really, there was this movement to get folks into brick and mortars. And, at the end of the day, the street medicine movement doesn't really feel like that is the end point for a lot of these folks. It's not a practical endpoint, and it's not what the folks want. So our philosophy, much like a lot of the other California street medicine groups out there, and USC really sort of takes the charge there, is just meeting folks where they're at, right? You've just got to meet folks where they're at. You've got to work in understanding their goals, both as individuals and as communities. And if we can better understand that, then we can work to navigate those goals together. Now, those goals are complex to achieve, right? Because it's taking permanent supportive housing, which is a goal. It's not the only goal, right? And ensuring that they have all of the healthcare needs for them to be successful in that permanent supportive housing space. And a big one's behavioral health. So if we're not delivering behavioral health, and that includes, we define behavioral health as mental health or psychiatry services, addiction medicine, as well as behavioral health counseling. So if we're not providing those services to those people in the streets, we're never going to get there, right? And the systems that are currently set up, LA County Department of Mental Health, despite all of the good intents of that system, it takes at least 12 weeks to get an appointment, right? So you've got people that are living in the streets. If you think that they're gonna wait for that appointment for 12 weeks, at which point they can decompensate further, and then end up in the ED, probably forgot about that appointment to begin with. And that appointment doesn't matter if it's, 3 blocks or 30 miles away in a place like LA. I mean, the ability to get there is going to be seriously constrained, mostly because of the social determinants of transportation. So all of these elements make it really, again, that syndemic sort of perspective. All of these sort of converge into sort of one place, and they amplify, and it make it very difficult for these populations to navigate. So it's very easy for us to just point fingers and say, oh, it's all them, it's all drugs, it's all mental health. That is a part of it, but as most of it is because the way that the system is set up, it is not set up for success for these folks. And there are a lot of these externalities that sort of come into play, whether it's the pandemic, whether it's increase in housing prices, whether it's the LA fires. All of these components sort of come together and impact people's ability to sustain their way of life. And if you look at the United States, at least a third, if not more, probably close to half of citizens of the United States or non-citizens are one paycheck away from being housing insecure, right? So you just take that one blow, and that's it. They're out. They're on the streets, and
which is quite a shocking statistic if you think about it. I think the rest of the world will be surprised about that 1 in 4.
Yeah, and I mean, when it comes to the other OECD countries, homelessness is yes, homelessness exists, universally, globally, but in the States, especially again in California, for a number of reasons, the problem is really sort of magnified. So we really do, it's that information is powerful, and there's a lot that we can do as a community to help these folks. I'm a doctor, so I focus on the health and the wellness. And Peter, the focus of your podcast, I think, is really meaningful here, because the genesis of our organization, Wellness Equity Alliance, was to really kind of focus on how we could meet folks where they're at. And mostly, our focus is the historically marginalized communities. That's our space. But we didn't call ourselves Health Equity Alliance. We called ourselves Wellness Equity Alliance because we wanted to go above and beyond just physical health, right? We wanted to go into all those other sort of, domains or dimensions of wellness. And we don't think that wellness necessarily just needs to be, all yoga, organic foods, chia seeds, right? Like, we think that, wellness could be a lot more, and we could provide that to historically marginalized communities right now. We're actually working on a program in New Mexico. We're actually trying to provide complementary alternative medicine, yoga, acupuncture to these folks, because there's actually emerging evidence that this can actually be very effective for all communities. And when we're looking at sort of, alternative modalities, something like behavioral health, there's not enough conventional behavioral health practitioners or providers out there, so we have to get sort of creative.
But what is striking is the differences in terms of access to wellness. And we're not talking about living very long time and longevity, we're just talking about wellness today. And if you compare the communities that you're talking about with perhaps those communities who consume the chia seeds and look at the vegan protein and think about their yoga class every day, the gulf is enormous. And I think the challenge is to try to bring everyone together in terms of looking to the future.
Yeah. There was a, when the focus being sort of living longer and living well, there was a recent study that came out, and essentially it was looking at California and the fact that we're actually, since the pandemic, longevity is not increasing. It's stagnant to decreasing. that's a serious concern. I mean, this is now, 5 years since the beginning, over 5 years since the beginning of the pandemic. And this is California, right? We should be leading. I'm based in the Bay Area, but I go back and forth to LA all the time. We should be leading the charge in terms of sort of advancing longevity, and not just survival as a goal in and of itself, but survival and living well, right? Quality is key here. And so the fact that we're going backwards is really unfortunate, and I actually made some comments in LA Times that I think that it's largely because we put our foot on the pedal when it came to the pandemic hit us. We realized, wow, there are lots of cracks in the pavement, right? Lots of cracks in the pavement, and that's sort of when you have a massively seismic event like the pandemic, those sort of cracks, those tectonic sort of plaques increase further, and so the first folks to really fall through those cracks as they sort of enlarge or widen are the most historically marginalized, right? Those are the first that come through because they're not engaged in primary care, right? They don't know how to navigate the systems. They're not engaged in prevention, right? Because a lot of time they don't have the health education to really sort of understand that. And so when those folks are falling through those cracks, the systems that exist, the public health and population systems that exist in order to absorb and to provide sort of safeguards around the entire population, they get gummed up, right? They get gummed up. And so the capacity for that system to then provide services to just any suburban or privileged or sort of blue skies, your aunt, uncle, wife, spouse, whatever, trying to get in just because they're having, a heart attack or something like that, their ability to get in is going to be seriously compromised, right? And so the entire community, whether we like it or not, whatever your politics are, the entire community is going to get sort of impacted. So we realized that during the pandemic. I mean, there was tons of data points on this when we looked at, the folks that were the most at risk of not just infection, but the adverse sequelae of infection were, largely socially determined, right? It was obesity. Those that were chronically obese or morbidly obese, those were the highest risk of not just the infection, but again, the adverse consequences of those infections. Black and brown communities. Why? It's not because it didn't have some sort of, predilection for melatonin, right? This is because of these communities that are most at risk of inaccess, right? And a lot of that is socially determined. So all of those components that we saw, we started to invest more. California has something called CalAIM, which is our 1115 Medicaid waiver. So we focused on innovation and enhanced care management for the most historically marginalized, as well as a few other programs, community supports, and a few others. And we have contracts for those programs, and they work relatively well, but we took our foot off the gas, right? And we took our foot off the gas too early, and a lot of that we couldn't control because the feds were basically removing a lot of that sort of support. And so as a result, we went a few steps forward, but we went several more steps backwards. And again, that's where we're at right now with survival. And so it's those historically marginalized communities that are skewing those numbers, right? And so if we want a healthy and well society, we have to focus on everybody. We have to, or the data points are going to continue to reflect this polarization in society. And if that's what we really want, as a society, okay. But I don't think that's most of the folks that I know on both sides of the political spectrum. That's not really what they're sort of seeking.
And of course, it's impossible to separate that aspiration for wellness for everyone from the current political situation which you referred to earlier. And there is, and I don't want to go too far down the road of politics, but it is overshadowing everything in terms of some people feeling that they really have no role in society because of things changing at a political level around them. And there is a certain desperation amongst some people.
There is a sense of desperation. There is a sense of a lot of folks that I know, particularly they're working in, some of the sort of frontline services, education, healthcare, government resources, paramedicine, et cetera. they do feel hopeless. They feel hopeless and helpless, and that's unfortunate. I don't. I feel as if we have a lot of work to do. I feel actually as the government systems are for them. The reality is the government systems are receding further. Now, my hope is that the pendulum will swing back, and we will sort of recover a lot of the steps, a lot of the sort of the receding steps that we've currently been or recently or currently sort of seeing, and hope, and I think probably will continue to see. That's the short term. I think in the long term, again, that pendulum will swing back, and we'll be able to kind of recover some of that. Having said that, right now I actually see that organizations like ours that are working in the private sector actually think we have more agency because there are more gaps. So there's more. The people are going to continue to be sick, right? That's just the reality. They're going to continue to be sick. In fact, they're going to get sicker because they don't have those prevention mechanisms there. They don't have those sort of government systems there that were already anemic to begin with, but now they're getting even sort of further anemic. And so it's really going to depend on the private sector and community-based organizations to get out there and to work harder to fill that gap. But I think that there's more opportunity. It's more work, but there's more opportunity for us to do things and to do them differently. I think that again, I'm an optimist, so I'm always looking for opportunities. What the current Secretary of Health and Human Services, what trying to get into his mind, and that's challenging to do. But if I try, what I see is somebody who's saying, you got to bootstrap this, right? We're looking for communities to bootstrap their health and their wellness. And he actually does believe a lot in wellness. Doesn't really quite understand the science behind it, but I think that there are opportunities to really sort of get in there and do things differently, because we had status quo for many, many years, decades, right? We had the status quo. We had these safety networks. We had federally qualified health centers, which were a part of the safety network. We have safety network hospitals, et cetera. The problem is it doesn't work as well as it should. There's amazing humans that are out there, docs, nurses, epidemiologists, community health workers that have broken their backs to try to sort of make these systems work. But the way that the systems are set up in the U.S., it just doesn't work in the way that it should. So there are so much more that we need to do. So I actually think the silver lining here is our ability to reevaluate where we're at and reconfigure it, right? Because when we look at the way that the systems are set up, I always look at National Health Service in UK, Peter, which you're probably from, yes?
Yep. You can tell.
The integration of public population, direct clinical services, the integration of all those services into sort of one program is ideal. Now I know that's I have a lot of British colleagues and they complain. So there's a lot of imperfections in every system, but I think that system, as well as other systems throughout Asia and whatnot, are systems that we can aspire to. And I read a lot about that in my book too. The first section is all about social medicine and the social determinants and why it's important. Again, this is for a lay community. So I really try to demystify, and I try to take away a lot of the unnecessary academic or sort of pompous sort of language or pedantic language that we often see in our journals or whatnot, to make it as digestible as possible for all communities to read. I'm sort of channeling my Malcolm Gladwell as I write the book, just to make it really as understandable as possible. And so I break down systems, because we often talk about systems either academically or abstractly, and I thought deeply about, well, I really think we need just a primer for systems, really for lay communities to really understand the way those systems are set up globally. So I write about that a bit, and I think getting to the point that you were I think sort of eliciting here, I think what we need to do is reevaluate, and then reconfigure our system. And so I think that's an opportunity for us right now. That's a silver lining.
And when it applies to the pandemic, which 99.9% of people will now associate with being a pandemic, COVID-19, ask people 5 years before 2020 about a pandemic, and it was just a historic thing that they didn't really know much about. But it is now very much a reality. And looking to the future, what key mistakes were made, do you think, in terms of, again, putting this in a very lay perspective for the future? Because you say in your book that it's very likely that most people will experience something similar in their lives to come.
We will. Thank you. That is the core. That's the premise of this book. So thank you for asking that. Right. So pandemics, in the simplest possible way to describe them, essentially are infectious disease outbreaks that become epidemics. So that is beyond any sort of reasonable or expected distribution of disease. That reasonable or sort of common normal distribution of disease is called endemic. And so anything that goes beyond that is epidemic. And then anything that essentially crosses borders, and it gets a little bit more complex than that, and I define that in the book, it becomes a pandemic. So international epidemics essentially become pandemics. The way that I define it, you have to hit a certain number of, there has to be a certain number of mortality or casualties for me to sort of describe it in the book. But yes, there actually have been several pandemics. I essentially, this is all in the second section, I start with plague. Now, most people think plague is completely some eliminated or even eradicated disease that, died with the Victorian age or something. It is very much alive. In fact, there was an outbreak of plague here in California recently. It's Yersinia pestis. It's typically through rodents. It's not something to get too concerned about, but the reality is plague still exists. So this was during the third plague, 1899 and beyond. And so I start with that, and then I end with COVID-19. But there are a number of pandemics that we have experienced, and some, if we're dealing with sort of folks that were, centenarians or beyond, that have actually even sort of experienced several of those, right? And many of those were influenza pandemics. So we have, the H1N1. We had just recently in the last 30 years, H1N1. We have HIV. We have Ebola. We have COVID-19. And then we have all of the other top infectious diseases that are the biggest killers or have the largest impact in terms of morbidity as well. And that's your pediatric diarrhea. That's your tuberculosis. That's your malaria. And these are diseases that not a lot of folks think that they are in the US or OECD countries. They don't think that they're necessarily at risk for. But the reality is, just like the COVID pandemic, while, people may think that they're separated, in terms of sort of, space, they do impact the systems. And the more that we remove the detection and the response mechanisms that public health systems are set up, a good public health, the way that I describe it, a good public health system is one in which the communities don't know it actually exists, right? It is almost a silent sort of mechanism that, again, creates those safeguards around communities and, could be helping to provide the health education and the protection modalities, but it does so in a stealth-like manner that people don't need to be too sort of, concerned with that. That is probably the most effective sort of public health mechanism. And so as the book sort of demonstrates throughout all of these pandemics, we have continued to make these mistakes over and over again. And we're doing the same thing right now, which is essentially removing those safeguards, removing those abilities for the most historically marginalized to gain access, to give them a fighting chance. That's equity. That's what equity is. That's very different from equality, right? So equity is basically providing more access, more help to folks that are struggling the most. And it doesn't necessarily matter what your politics are, okay? And that's really what the book is. The book really tries to make the argument. It doesn't matter if you're on the left or the right. Humans are humans, right? And at the end of the day, if the system is so jammed up, right? That's what we were talking about earlier. If the system is so jammed up, it's going to impact you as well. And so it's all these concentric circles of impact. And if it doesn't impact you from a material or from a direct clinical service standpoint, it will impact you from a material standpoint. It's going to impact your local budgets. You may not be aware of it, but it is impacting your budgets on a city, town, county, state standpoint. So being really mindful of that is really important. But again, the focus of the book is if we continue to regress more and take away these sort of central elements that are there for prevention and detection and response, then we are going to basically provoke the next pandemic. And we have to work harder, because when we're looking at climate change, I just talked about this on a news channel on Fox the other day. There's a increasing outbreak of Vibrio vulnificus, which is essentially this flesh-eating bacteria. It sounds very scary. It's not as scary as it sounds, but the reality is it has increased roughly tenfold in the last 20 years. Why? Climate change, right? So we have to naturally be able to detect this. And we've had a lot of advancements in our technology, and our ability to looking at, wastewater, for example, is brilliant, being able to kind of use that as a sample. But the more, again, that we're removing these sort of elements, and again, importantly, the response, the more that we're going to sort of set ourselves up for disaster. And then the last piece I'll say, and then I'll stop, is the coordinated response is key here. And so we are going to have epidemics, outbreaks, epidemics, and possibly pandemics. But it's how quickly we respond to it, which determines essentially, how much impact, how much devastation will exist. And so what we learned during the last pandemic, but unfortunately we're not sort of sustaining, is that responding as early as possible is key. And when I'm talking about responding, I'm talking about responding from a clinical standpoint, but also from a communication standpoint. So what's key is having central federal agencies working with the states in a coordinated network, not having a bunch of different people talking about a bunch of different things, right? Because that's going to confuse the communities. And that leads to the divisiveness that we are currently in. So if you have the feds working with the states, who are then working with the municipalities, who are then working with the communities, all in lockstep, and this is very, very possibly done, and it is well done in other countries. If you have that taking place with the community health workers being sort of the trusted messengers to the communities that look, and the communities that sort of have the faith and trust of those folks, that is an effective response, and that's how we can mitigate any potential disaster in the future.
But a big part of what you're saying is that it starts with awareness, and I think essentially this is what you're trying, as a starting point, this is what you're trying to do with the book, that it's more than just thinking about personal health, that community health will ultimately affect us all, and that perhaps is the aspect that many people don't give any thought to. Yes.
Awareness is key. That is the ultimate endpoint of the book. As a baseline success, if awareness is the only win, I'll take it, right? Because that collective awareness is going to follow folks to their voting booth, to the ballot, right? To be able to connect to their communities, right? To understand more. Knowledge is power, right? I know that sounds cliche, but it really is. And a lot of folks have turned off, right? Because they're in their echo chambers of their social media and their subscription, their news channel subscriptions, and whether folks are aware of it, I mean, they're strongly politicized. And so we've turned off, right? We've turned off open minds in a lot of ways. And most Americans, most humans throughout the world, I've traveled to over 120 countries, and I find a core universal theme among most humans. And most humans want to just, they care about their communities. They care to some extent about the globe, but they really care about their communities, how to protect their families, how to get food on the table. But they ultimately, they want to serve humanity in some extent. There is such a charitable element that exists really, across the world, and the amount of privilege almost doesn't matter. In fact, sometimes I see a sort of it's inversely proportional. I see a lot of folks who are more kind of low income communities that actually want to help more. But the reality is there is a core humanitarian element, I think, to many of us. And so the more that it's activated and the more that it's evidence based, right? That's what the book really tries to demonstrate. This is not an opinion. These are facts. And the facts are, that every pandemic that we have seen has had a very profound social and political driver. And until we address those, we will continue to see more of the same. And that's what the third section is about. Okay, now that we've got your attention, now that you are hopefully in agreement here, what can we do about it? And again, if you just are aware, that will influence your actions in sort of years to come. And that could be, again, that could be just voting. That could be, calling up the quintessential, calling up your congressman, or volunteering at the local shelter, or whatever. But it doesn't even have to be that collective awareness. Posting that on your echo chambers, because it's just going to get worse, I'm afraid, and that will disrupt the current paradigm and hopefully start to kind of break down some of these sort of perceived barriers.
And just in closing, and more of a personal question, can you give me a snapshot of how you live your life with these goals and these big aspirations in mind in terms of everyday living?
Sure. I try to lead by example. So, talking on the media circuits and, working through a lot of these virtual sort of screens, but I'm still seeing patients. I'm still seeing patients. I'm still trying to work to improve these folks' lives in meaningful ways. I'm still meeting with our teams, not just on, Zoom or Teams. I'm there, in person, trying to strengthen the solidarity that we have. I try to really inspire leadership among our local teams. We now have multiple teams across the country, and I really try to be there as much as possible, again, so we can sort of inspire them to do more. I try to create some of that sort of self-care. It's hard, I wear a lot of hats, so I try to create some of that self-care space as well. I think my wife, hopes it would be a little bit more, but I'm there for the kids. I'm taking my 5-year-old to the pediatric dentist today to talk about oral health. So that's my sort of, my personal way of sort of, engaging in my own sort of, family's health and wellness. We have fun, we travel, sometimes for work, sometimes for fun, exercise, regularly, read, continue to kind of feed our minds. That is such a prevention mechanism for, neurodegenerative diseases and whatnot, keeping our minds sort of active, just being diverse and engaged, human, but really being there, leading by example, not just talking about it, is really important to me.
Yeah, that's great. Tyler, this has been an inspiring conversation. It's a great book. It's a deep dive, much more detail, obviously, in the book than we've had time for in this conversation. The book is Pandemics, Poverty and Politics, Decoding the Social and Political Drivers of Pandemics from Plague to COVID-19. Dr. Tyler Evans, really good to talk to you. Thank you very much.
Thanks, Peter. Great conversation.
The Live Long podcast is a HealthSpan media production. I'm Peter Bowes. You can contact me through our website, livelongpodcast.com, where you'll also find show notes for this episode.
This podcast is for informational, educational and entertainment purposes only. We do not offer medical advice. If you have health concerns of any kind, or you are considering adopting a new diet or exercise regime, you should first consult your doctor.